Good morning, everyone. My name is Maya Luria with TMC for Seniors, and today we are back discussing our diabetes education. We have Diabetic Wound Care Essentials, what you should know. I have Natalie Norem here with me. She is a family nurse practitioner. She's board certified. She is with our TMC Wound Care and also with our TMCOne Wyatt Primary Care practice. How are you today, Natalie?
I'm great, and thank you for having me. Happy to be here.
Good. So I have, you do have an online audience that's watching. If you're watching from home, please feel free to put any questions into the chat and I will ask Natalie when she is done with her presentation. She also has an in-person audience. So welcome everyone. I've gone ahead and put your PowerPoint up for you so that you can get started.
Thank you for the introduction, Maya, and hello to everybody. She already introduced me, but I'm Natalie, and I did this talk last year. I really enjoy talking with our community and patients, and so I'm excited to go through this presentation with you all today. When you look at the slides, you're going to see on that lower right-hand corner Helogics emblem. Our wound care center here is TMC based, but we partner with a national wound care company called Helogics, just in case you were wondering. We follow all their protocols and standards. I don't have any disclosures to provide, no financial interest or any other conflicts of interest. This is myself with one of my dogs. I have two, and my two kids. Just a little bit about myself. I've been a nurse practitioner for 16 years now and a nurse for 22 years and 16 years in primary care, urgent care, and wound care. So that's kind of my background. And in those primary care visits, lots and lots of diabetic patients. So let's talk a little bit about diabetic statistics. They're a little astounding when you look at the numbers in our country. There's 28.7 million people in the US who are diagnosed. 26.4 million people over the age of 65 have prediabetes. So that's almost half of people as they get into their elderly stages of life have prediabetes. And for purposes of our discussion, what does prediabetes, what's the difference between that and diabetes? Because I get that question a lot. Prediabetes is when your fasting blood sugar is between 100 and 120, that first blood sugar in the morning before you eat anything. When you get over the 120 range, you get into the diabetic definition. Your provider, nurse practitioner, or doctor may do an A1C on you. So if your A1C gets to be between that 5.8% and about 6.1, 6.2%, that's that diabetes range. Prediabetes, excuse me. That being said, we still have a lot of people in our country who are not diagnosed. So 8.5 million that are undiagnosed and running around there out in the world until they have some kind of health problem that forces them to seek medical care, and then they get their diagnosis. So 11.3% of our population has diabetes. So you can see that this is a very big problem. And then 38% of the patient has the pre-diabetic syndrome. Do all pre-diabetes end up with diabetes? Not necessarily. But it's hard for us to predict that when we see you in the office and see your sugars going up. Some of you may stay pre-diabetic for many, many years. Others are ending up with diabetes just in 1 or 2 years. So what causes diabetes? It's really a very multifactorial disease. So we can't just pinpoint it to one thing. We probably are all familiar with type 2 diabetes, and that's what we're talking about mostly today. And the main cause of that is obesity. Type 2 is typically the diabetes you get diagnosed with as an adult, not as a child. Genetics and lifestyle contribute to this as well. So we can definitely see strong genetic factors in families. If you had parents, grandparents with diabetes, you're more likely to get it. And then, of course, your lifestyle. The more sedentary you are, the more processed foods that you eat, you're more likely to get that diabetes diagnosis. Now, when we talk about foot care and wound care, we do worry about the other type of diabetes as well, and that's type 1. Type 1 is when your immune system attacks your pancreas for one reason or another. There's lots of research out there about why that happens. And your pancreas stops working. Your pancreas is the organ that creates insulin. Insulin is instrumental for us to digest our food and use the glucose that comes out of our food and get it into our cells. So in type 1, you totally stop making insulin. In type 2, you actually have too much insulin. So it's more of a slow, insidious process where your pancreas starts making too much insulin and your cells say, why do I have all this insulin coming in? And they become resistant to it. So funny how there's two opposite causes, but they are called the same thing, and the endpoint of complications are the same thing. You may also notice or have heard of people getting diabetes when they're pregnant. That's called gestational diabetes. And then sometimes medication can cause diabetes. So if you're a patient who's had to have a lot of steroids, maybe you have rheumatoid arthritis or something like that, it can induce diabetes. It's really a disease of our modern lifestyle, and that's kind of what we're seeing in the large numbers in our country. It is a multifactorial effect on our body. It doesn't just attack one thing, it attacks multiple systems. And you can see in this slide here all the different areas of the body that it can affect. It increases your risk for stroke. It increases your risk for having a heart attack. It can attack your arteries and your veins and cause complications of circulation in your legs. It's very hard on the eyes, and it can lead to blindness in severe cases. But you can see here diabetic retinopathy. That's where it damages the little tiny delicate vessels in your retina. It can cause cataracts. It can contribute to glaucoma. It can cause kidney disease and dialysis. And then it can attack the nerves in your body and cause the painful burning neuropathy or even numbness in those feet. And then we're going to talk about specifically the foot today and why that's so important with diabetes and why we want to keep an eye on our feet. These complications most of the time are 100% preventable. So with good management of your diabetes, you can avoid a lot of this. When I talk to patients about their diabetes, I often say that diabetes is like a fire, and it kind of smolders in your vascular system, and then something will happen and it takes off, and you have one of these events where you have a forest fire take off, like a heart attack. So we, as the medical system in prevention, try to decrease that fire from taking off, and that's by taking medications, eating that good diet, being active, all those good things. So let's talk specifically about feet, which is what we're here to talk about today. In your lifetime, you're going to walk approximately 100,000 miles, which was a pretty amazing statistic to me. So when we wonder why feet are so important to people, there you go. 60 to 70% of people with diabetes develop that neuropathy that I was talking about. And when you get neuropathy, that's where we start to see those complications set in. Chronic foot pain is a huge impact on your quality of life. So if you've ever had a foot injury or a sprained ankle, how that affected your life from day to day was pretty impactful. And then once you lose that mobility, it leads to other problems like depression and osteoporosis and your weight going up, which then in turn makes you more at risk for heart disease and stroke. So that's why we care so much about these feet. So here, we'll start off with some of the complications of diabetes. Diabetic ulcers, we see these day in and day out over at our wound care center. And this is a very typical one where you see it on that second metatarsal head, on that plantar surface or the bottom of the foot. So we're going to talk about why these develop and what you can do to prevent them, because of course prevention is the best medicine, right? Peripheral neuropathy. So let's start with that topic. Peripheral neuropathy, peripheral meaning the outside parts of our body. Central would be your spinal cord and your brain, but so your arms and your legs. Neuropathy meaning that there's a disease of those nerves in your feet and your legs. And there's 3 types of complications the diabetes can. Over time, if you have elevated blood sugars, it attacks those nerves and it makes them inflamed and it breaks them down and they can't work like they're supposed to. So you can get sensory changes. So those can range from stuff like, I can't even feel the bottom of my foot. So when I was walking around on my patio, I didn't know I stepped on a cactus thorn and now I have a big sore on my foot that maybe, before you had diabetes, you would have noticed right away, but you didn't notice it for a week until it got really bad. So we often see that. The second part of that is that you can lose some of the normal structure of the bones in the foot. You need your nerves and your tendons and muscles to all work together to support your bones. And when those fail and your nerves start to degrade, your bones can kind of sag and it can cause deformities where it rubs from the inside out. And that's what I think is going on with this patient, because you can see on his or her second toe, there's a deformity there. So probably over time, the nerves wore out, the bones sort of followed, they got deformed, and then there's a rubbing that happens. That combined with loss of sensation, you don't know what's occurring, it gets you into trouble and you get this ulcer. The other part is the autonomic. So autonomic is our nervous system that controls things like digestion or breathing. We don't think about it, it just happens. We also have autonomic problems in our feet. So you can get changes where you have excessive sweating because the nerves are sending too many impulses. So your feet are really moist, you get skin breakdown, you get fungal infections. On the flip side, it can go the other way where you don't get enough moisture and you get dried out feet. They crack, they bleed, you get pain. So these are all causes of damage. And as you can see, this leads to infections, it leads to circulation issues as well. So here's just another picture talking about those 3 types of diabetic complications. The sensory, where and I didn't mention, you can get numbness, but you can also get the burning and really painful. And for some patients, that's a huge quality of life issue. They can't sleep, they're in chronic pain all the time. Then that autonomic neuropathy there in that second picture, you can see that patient has very dry, cracked skin. That little crack is the technical words, a fissure. And we can see those get infected and cause an ulcer on the foot. And then in that last part, that motor neuropathy where the nerves break down and then you get the bone deformity. And you could see how easily how a foot like that would get blisters and ulcers just from normal walking around day-to-day wear and tear. And I should have mentioned at the beginning of the talk, we are going to have time for questions. So at the end for sure. So if you have questions, you could write it down or remember and bring it up at the end. And then infections. So diabetics or people with diabetes are also at increased risk for infections. It can kind of wear down your immune system. It doesn't work as well, especially when sugars are high. Your immune system does not fight infections like it should. And in the feet, these common infections are things like fungus. And I hope my pictures aren't grossing any of you out today. You know us in the medical world, we like gross things, but I know patients don't always like them.
I could take off my shoes and have something like that.
You want to be my model?
Yeah, I could do that.
So I'm sure we're all familiar with athlete's foot, medical terms tinea pedis, more common in diabetic patients, and then we can see those fungal infections of the toes. When those get advanced, they can break down the skin, cause infections through skin breakdown and wounds. And if the wound gets deep enough, it can go all the way down to the bone, and then you get infection in your bone, and that's a very serious infection. It can be very difficult to clear up. The medical term for that is osteomyelitis. So let's go on to talk about the vascular system in the leg, because that's a really important part of wound care and diabetic foot care, because you can imagine if you don't have great circulation to your feet, how are you going to take good care of them? So there's 2 types of vessels in our lower legs. There's arteries and veins. Arteries carry all the nutritious oxygen and nutrients from our heart down to our foot, and they give oxygen to the foot. The vein takes all that, and once the blood has gone through all the tissues and cells, and returns all the blood back up to the heart. So when we're talking about vascular disease, there's the 2 types, artery and venous. There's a couple different ways that this can happen. The first thing is the advanced glycogen end products are ages, and they do just what they say. They age you. When you break down materials, you cause something called oxidative stress, and then this leads to inflammation in the walls of those arteries. And when you have elevated blood sugars and smoking and high cholesterol, all these things work together to increase that process, and it speeds up the inflammation and aging process of your arteries and leads to blockages in the arteries or arteries that don't perform well. And that's what that dysfunction of the endothelial cells is. The endothelial are the lining cells. And once they get inflamed, they don't work well and they can't carry all that good blood to your foot. Dyslipidemia, which is another name for high cholesterol. I'm sure your primary care, hopefully, or your cardiologist has talked to you about your cholesterol levels. That's why we care about them. High cholesterol also leads to inflammation in that wall, and it can lead to blockages in those legs where you don't have good blood flow. Some patients with their genetic predisposition just have bad arteries and they don't flow as well. So we do see that. Lifestyle factors, smoking and tobacco use is a huge problem with arterial disease and causing foot wounds, and combined with diabetes is really a bad idea. I'm glad to see that in my career, I've seen decreased smoking rates, and I continue to counsel patients that smoke and try to help them quit. Lifestyle factors, being sedentary, your calf muscle acts like a pump in the lower leg. And what it does is it acts to tell the blood to come back up against gravity to your heart. If you're not exercising or active, you can't get that pump going. All that blood sits in your veins and your lower extremities, and it causes swelling, which can break down the skin. So we definitely want you to be active. On the other side of that, the more active you are, the better your arteries function, because they're having to continually repair themselves, work, be resistant, and they're stronger. They're kind of like a muscle. You want to work those arteries out just like you do your muscles when you're exercising. And then the two types of vascular complications, the macrovascular. So if you've ever heard of someone or maybe yourself having a stent put in an artery, that's a bigger vessel where they're trying to open up that artery and help the blood flow through. And then microvascular. So specifically in diabetic patients, we can see the tiny little delicate vessels, the tiny ones that feed your toes that we can't even really see very well without a microscope. They can get damaged from the high blood sugars, and then you start having poor circulation to the toes, and that's where we see toe amputations, toe ulcers, that kind of stuff. This picture shows a patient with a very common thing we see over in wound care, and that's a sort of venous stasis dermatitis and change to the skin. That's from long-term poor return of blood flow up to the heart through that vein. It sits down in the lower leg. It causes a pressure to increase in your skin. Your skin responds by getting thicker. You get the darkening hemoceridian deposits, or little iron deposits. And then over time, it can get to such a level that the skin starts to break down and you get a rash or even an ulcer. Welcome to the new people that just came in.
I got lost.
No worries. We're happy to see you.
Okay.
So one of the things I always talk with my diabetic patients about is a daily foot exam. That can be hard when you have orthopedic issues, especially if your hips don't bend like they used to, or your back is hurting you and you can't get down to your feet. So there are some tricks, especially if you live alone and you don't have a partner or someone in the family to look at your feet. Sitting down to do it and kind of crossing that foot over and looking at your foot is a good trick. They sell very inexpensive mirrors that are on a handle. You can buy them on Amazon, or you can buy them at the pharmacy. And that way you can kind of look at the bottom of your foot. But it's a really good idea, especially if you've lost sensation in the foot, because you're not going to be able to tell when you start to get an ulcer. If you see any rashes, any skin breakdown, any really thick calluses, and you're like, this doesn't look right, get in, see your primary care. If you have a podiatrist, get in and see your podiatrist, because these things are much more treatable if we get on them quicker, okay? And sometimes when you get real thick scab build up the skin, we remove that. There's actually open ulcer under there. So that's why I mentioned that thick callus. We want to keep an eye on things. If you have poor circulation, then you definitely want to get in to see your provider. So if you're noticing in that prior picture that you've got skin changes like this, you need to have that checked out. You probably need some ultrasounds of the legs, and you need to start with your primary care, maybe even a vascular surgery consult. Things like compression and different emollients and lotions can help keep that skin, a compression wrap, and can keep that skin under good control so it doesn't break down. Same with the feet. So if you're noticing that your feet have like a bluish or a white color, they feel really, really cold all the time, you get pain when you're active, and you're trying to increase your activity in your calf muscle, those can all be signs of arterial disease. Some patients will tell me, gosh, I put my foot up in the bed at night and it hurts so bad I have to dangle my leg off the bed. Well, that's because gravity's not your friend when you're lying flat. And it is when you have your leg dependent or on the side of the bed. If you're having pain like that, you need to get in and see your doctor right away, or your nurse practitioner. If you're having a lot of trouble with foot deformity, rubbing in your shoe, get a podiatry referral, get in, see that podiatrist, because they can fashion little what we call offloaders So offloading is taking the pressure off certain points of the foot. They have different shoe prescriptions they can write for you. They have different foams, felts that they can fashion specifically for your feet to make sure that you're not going to rub and get a sore, okay? Dry and discolored skin, again, seeing your podiatrist or your primary care, they can recommend certain kinds of things. I love Vaseline. It's cheap, it's easy, put it on dry skin. It's very, what we call an occlusive emollient. You can put it on at nighttime. A lot of times it's kind of greasy to wear during the day. That'll keep that skin from cracking, breaking down. But sometimes you may need an antifungal powder or maybe some other clinical input. So getting in and seeing your provider and getting some more input about how to take care of your skin. It's really good to try to keep those toenails trimmed and not let them get too long. It can be hard when they're fungal and they're super thick, or if you're having orthopedic issues where you can't get down to your feet. So talking with your primary care about a podiatry referral, having a family member that can help with some of those things are always a good idea. I don't want you in wound care and seeing me for that ulcer. So keep an eye on everything. So if you do end up in wound care, what happens and why do we do all these things in wound care? One of our cornerstone of our treatment is debridement. And the reason for that is because when wounds get to be a week or two old, they get a bacterial kind of burden that's not helpful for wound healing. Your skin is one of the primary functions of your immune system. It keeps lots of bacteria and viruses and fungus and things out of your body. When it breaks down, it's an opportunity for bacteria to kind of grow in there. When we see patients in wound care, we use things like scalpels and curettes to kind of clean off that bacterial burden. It improves the healing, it decreases healing time. We also have dead skin cells and things on there called slough, and it takes that out. Slough interferes with wound healing as well. And it also has this sort of mechanical effect on your body where it's telling your body, I have a sore and I need you to send all your healing cells down to this sore and I need you to heal this. So if your body's being a little reluctant for whatever reason to get something healed, it can kind of wake up your immune system. When we try our routine first line treatments, which are some different types of dressings, things that have collagen in them that promote collagen growth, we have antibacterial dressings. If those don't work, we can go to cellular and biological products. We have lots of products now that are available, things that are made from pigs, cows, sheep, human placental cells, umbilical cords. They use live biological cells and they put them on a little backing. We have to do a prior auth with insurance because of course they're expensive, but if you qualify, we love to get them for patients. And we put that backing on your wound and we see you every week and keep an eye on it. And sometimes that will wake up your own body's immune system. Those cells embed into your wound and you start to see healing. So that's a pretty cool technique. And I always enjoy seeing those work. We also have a total contact cast. So you can see in that top picture, what that does is it essentially is just what it's saying. We put you in a huge cast and it goes from your toes all the way up to your knee. And it's designed so any sort of pressure that's on just one part where the wound is, it's going to spread that pressure out. So you're not just putting when you're walking all the pressure on the wound and then it can't heal, it spreads it out. Those work so well. I just have a hard time getting patients tucked into them because they don't want to have that huge cast and walk around. But if I can get a patient to do it and they're appropriate, if they can wear that for 2 or 3 weeks, we can see a lot of healing. And then they're saving themselves 3 months of wound care. So if you ever have a wound care provider, suggest it, be open because it really does work and it's a nice tool. The cast gets changed weekly in our wound care center. Negative pressure wound therapy. I don't know if you've ever heard of a wound vac or had a family member or seen a patient with a wound vac. It's just like you describe it, a vacuum. We make a seal with this foam product and then it attaches to a little vacuum device about that big that you carry in a bag. And it's constantly putting pressure on the wound to pull the edges together. So it really helps with decreasing healing time. And then our kind of last stop or sort of higher tier wound therapy is hyperbaric oxygen therapy. And you can see in that lower picture there, we have those chambers over at our wound care center. We have 4 of them. And what that does is it simulates you going under the water, like a diver would, a scuba diver, increases atmospheric pressure. When we have increased atmospheric pressure, we force oxygen into our tissues, and that aids in wound healing. So there's lots of good evidence that this works. It's quite a commitment for the patient. They have to come in 2 hours every day for like 4 to 6 weeks, depending on the treatment program. It can kind of bother your ears because you have to kind of equalize your ears, just like if you were flying on an airplane or something. Most people do tolerate that though. And you just kind of sit in there and you can watch TV and you do your therapy and you leave. So it works really well for those deeper wound infections we see on people's feet where we're having a hard time getting good blood flow, people that have arterial disease to the foot. So we're having a hard time getting that oxygen delivery. We also use it not related to diabetes. We have quite a few patients in our wound care center that have had radiation injuries that need radiation therapy based on the radiation treatments. And then acute hearing loss, which is an interesting diagnosis, but it does help with that too. So just to show you some more pictures of how awesome wound care can be and why we want you to get in and see a provider in a wound care center that has the experience as well as the multiple specialties it can take to really get a wound to heal. This patient came in, you can see on the far left there of how open that wound was. And after our therapies and offloading, a patient like that, I would say, wow, this person might lose their toe. But we were able to save it, and the patient did well. And if we don't find the wounds, we don't treat them, and we don't heal them, this is on the unfortunate consequence, and that's amputation. And we do still have a lot of patients who end up with amputation. This patient, unfortunately, has already lost their left lower leg, and it looks like you can see on that right lower leg a lot of changes from poor circulation on the right. And they have a wound you can see on that right foot. Amputation, besides being, obviously nobody wants to lose a limb and then it decreases your mobility, it decreases your length of your life. There are many patients that don't last after 5 years after losing their limb. So that's why we really care and want to prevent this stuff from happening. We don't want our patients to go down this route. And about 50% of patients, when they lose one leg, end up losing the other because the same process that led to the one leg amputation is still going on and things aren't under good control and they end up with another one. So it is very serious. So let's just talk about wound care a little bit more. Chronic wounds have a $50 billion impact on the healthcare system annually. And we see that growing need as we, as a population, have lots of chronic disease and diabetes is so widespread. 1 in 4, we kind of talked about this, have diabetes in 65 and older. 1 in 5 that are older than 60 have some type of peripheral artery disease. That's when I was talking about those arterial blood flow changes in the lower leg. 1 in 7 Medicare beneficiaries are diagnosed with a wound or wound infection at some point. Untreated wounds mean that you have 20 times more likely to end up in the ER, which I see. We have a lot of patients, unfortunately, that have a hard time controlling their diseases, and they end up wound care, ER, hospital, back and forth. 85% of diabetes related to amputations are preceded by a foot ulcer. So that ulcer or the skin breakdown is your first sign of something's not right here and I need to get this checked out. And 55%, I said 55% require an amputation on the second leg within 2 to 3 years. So I don't know why in the culture wounds don't get as much attention as cancer. I think it's because they're not glamorous. I'm not sure, but they're just not fun to talk about. And people don't go around saying, I have a wound. They go around saying, I have colon cancer. I think it's more embarrassing and that type of issue. But they are very significant for people in their health. And that was kind of what this slide is representing. 85% of diabetes-related amputations are preceded by that foot ulcer, and so you can see those two different types there, the diabetic, and then that Charcot's arthropathy. That's the orthopedic change. When I was talking about losing your nervous system issues in your foot, and all the bones kind of fail, and then you get lots of ulcers. That's a Charcot foot. So you can see there's higher incidence of those two things than breast cancer. And just the diabetic foot ulcer is at the same incident rate as cancer, all cancers combined. So that's pretty impressive if you really think about it. That 55% require an amputation on the second leg within 2 to 3 years, 46% minor amputations. Those would be things like toes. Chronic limb ischemia. Ischemia is a word for decreased blood flow. So the leg is losing good blood flow and oxygenation. And then 57% end up with a major amputation. So if you see all those percentiles of incidence rates compared to lung cancer, which is at 80%. So it really is a significant impact on people, their lives, their quality of life, and then their mortality, and our healthcare system and all the resources we use to take care of patients. So if there's one thing I want you guys to take away from our talk today is this is preventable. And, you know, we providers love to do fancy wound dressings and surgeries and all these things, but we really don't like that. We want our patients to not show up with wounds. We want them to not have problems, and we want them to do prevention. The patient is really the center of this, and the patient plays a very significant role in diabetes. It is very lifestyle dependent. How you eat, how you move through the world, how much activity you're getting, keeping up with your appointments, keeping on top of your foot care, those things do in the long run really benefit you. So we want to empower our patients and empower you guys to take good care of your health. We all know that diet is the cornerstone of treatment with diabetes. I can't say this enough. I mean, food is a medicine. If patients were able to or wanted to eat really, really healthy all the time and keep those blood sugars under control, I wouldn't be seeing them in my wound care center. And if there's a lot of misinformation about nutrition out there, I always recommend, if you do any reading, Mediterranean diet. It's time and time again, that's not really a diet. It's a way of eating. Has been shown in research to be great for our cardiovascular system. It helps to keep our blood sugar stable. And if you think about what kind of eating that is, the countries that go around the Mediterranean, they have lots of access to water, fresh fruits and vegetables. We're talking about places like Greece and Italy and Spain. Lots of seafood, lots of olives, olive oil, 5+, some people even say 10 servings of fresh fruits and vegetables a day, staying away from a lot of those animal products, red meat, those kinds of things, really helps with your health. Mayo Clinic has some good resources on Mediterranean food because there's a lot of bad resources out there on the internet now. Active lifestyle, I always recommend to patients, what do you like to do? What do you want to do when you move? That's what you should try to do. It's great to try to do cardio and strength training and those kinds of things. I really recommend like an all-around fitness program, but you're going to be more likely to stick to it and be happy if you're doing something you enjoy. So what that is for your life and what kind of brings you joy is what I recommend. If you have diabetes, it's really important that you know your hemoglobin A1C. That is the number that gives us the average of your blood sugars over the preceding 3 months. So be informed, be aware what your A1C is. The ideal one is less than 6.5% for diabetic patients. It can, depending on your situation, we may say 7%. Some patients even higher, but ideally for most people, 6.5%. And you should know that number and be aware. Ask your provider if you need to know. You should be doing a daily self-foot exam, making sure those feet look good, you're not having any issues or concerns, bringing them to your provider's attention if you do see them. Your primary care should be doing a foot exam on you every year, at least once a year. They should be checking your circulation, looking for skin changes, and there's a test called a monofilament test. You may have had it done before, where we poke the bottom of your foot with this tiny little probe. It doesn't hurt, just to see what your sensation's like. Wearing appropriate shoes. If you need diabetic shoes, you know, Medicare will pay for some of that. You can get prescriptions from your provider. Seeing a podiatrist if you have more complicated issues and need offloading. No smoking. Adding smoking to to diabetes is like adding fuel to the fire. It's just really bad. So if you're having trouble quitting smoking, please talk to your provider. We're really happy to help and work with you. The research shows that the average person takes 7 times before they quit. So I always tell my patients, never stop trying to quit. It is very difficult, but it's not impossible. Cholesterol management. Statin therapy is recommended for all diabetics because you're already at higher risk for having stroke and heart disease, arterial disease. So we want to decrease any of your other risk factors and get you on that cholesterol medication. We really want that LDL goal below 70. And now the cardiologists are even saying below 50. You really can't go too low with your LDL. So I know there's a lot of misinformation out there about statins. Please talk to your medical provider. They're the ones that really have the truth and the clinical knowledge. There's other options now versus statins. There's some injectables that you can talk to your provider about. So don't be afraid. Have the conversation. See what works for you with your provider. Blood pressure is really important in diabetic foot care. And why is that? Well, the higher your blood pressure and the more uncontrolled, the harder it is on those arteries and even the tiny ones in your feet. So we want to keep that top number under 130, that bottom number under 90. There are medications called ACE inhibitors and angiotensin blockers. These medications are really important for diabetics, not only to control blood pressure, but they help prevent kidney disease. So every person with diabetes should be on one of those medications, a statin, and then something to control their blood sugars and doing all those lifestyle stuff. This is just a couple other pictures I wanted to go over. That on the left there is that monofilament test that we do at the primary care office. We do it at wound care too, to check your sensation. And that's a picture of a mirror so you can see the bottom of your foot. And this on the left is one of those diabetic shoes. They aren't all that clunky. Trust me, you can't get ones that look cute now. They have a lot of options. But the insert there is something that your podiatrist can help you so it fits to your foot correctly and offloads those feet. This is just a case study. We'll skip to this one. Key takeaways. Diabetes is common, yet it's preventable and treatable. Foot wounds are prevented with good glucose control and proper foot care. Ulcers are more easily treated the sooner you are recognized and get in. Don't be afraid to ask somebody for a wound care consult. If you've got an ulcer that hasn't healed after about 7 to 10 days, I do recommend getting into a wound care center. And we know now that diabetic ulcers can be caused by multiple different factors: nervous system, orthopedic, vascular, and infection reasons. That's why wound care is so specialty oriented. We really pull in all of our partners to take care of our patients. And the nurses and doctors that specialize in wound care are really the best fit for some of these diabetic ulcers. We have our outpatient wound care center here at TMC, and we have a pretty good referral time getting you in pretty quickly. If this isn't not convenient for you on this side of town, St. Mary's has one. Northwest doesn't have one anymore. Banner doesn't have one anymore, but there are several providers in town that do home care. So if you have somebody that's homebound, that can be an option too. But of course, I think we're the best, and we are. We have a good team over there. Okay, these are my contact where I work. So if you have questions or concerns or want to get a hold of me, that's where you can find me. I'm going to open up the floor to all of you, and I think Maya's going to ask our online audience for questions first.
Thank you so much, Natalie. I am going to ask, and actually my first question for everybody is just tell us exactly where TMC Wound Care Center is located.
Sure. Yes, because it's not on the campus here. It's at the El Dorado campus is the old name of it. It's over on Wilmot between Pima and Speedway.
Yes. 1400 North Wilmot. So I just want to make sure everybody has that. It is the old El Dorado Hospital location, if you're familiar with that as well. So I just like everyone to know. We actually, TMC for Seniors used to be located there for many years. For about 15 years, we were also at that location, but we have since moved. I did have a couple of questions that came in, Natalie. One is, do you see similar types of wounds on other parts of the body, like the arm or the back, or is it mainly just the foot for diabetes?
Yeah, great question. No, diabetics are at risk for any type of wound. So we'll see wounds on other parts of the body. The foot is sort of the most common because of the circulatory issues that you get with feet and the nervous system complications with feet. But yes, you can we see diabetics who get abscesses on their abdomen, or they get a skin tear in their hand that turns into a bigger infection. So yes.
Okay, great. Does the Arizona weather impact foot ulcers, and what can you do to adjust for that?
Sure, it's dry here, and so we do have more of a problem with people having dry skin, which leads to fissures, which leads to cracks, and we see those infections start in the foot. So keeping an eye on your skin, again, that Vaseline at night, if you're one of those people that has dry heels and calluses, is a great option. When you're in the shower, if you use one of those bars that are kind of rough, I can't think, like a
loofah? That has like a loofah in it, maybe?
Yes.
Okay.
Yes, thank you. A pumice stone. That can also help. You just need to be very careful and talk to your provider if you have diabetes before you use something like that, because we don't want you to cause tears or anything on your skin. But yes, those are all good options. We do see a lot of dry skin here.
Okay, I had a question come in about asking about Meta Honey. Is that still advised for wound care?
So Meta Honey is a great option when you get a wound. What it does is it's a medical-based honey product. It softens that kind of scabby slough stuff that's on top of wounds, which impede healing. So if you're trying to do wound treatment at home and you want to try Meta Honey for a week or so, I'm an advocate of that. It's just that if it's not working after, say, a week, you need to get some professional help.
Okay. All right. So about a week, it sounds like, is when you feel like they should reach out for more help if they can't rectify on their own. Can certain medications put you at risk, more at risk, I guess, of developing foot ulcers and wounds? Would there any medications have any of that effect?
I think there is some warnings on the SGLT2 medications that if you have a foot wound, you should talk to your doctor about that, and if you should continue your medication. I don't think there's any increased incidence, but it may interfere with some of the healing. Those are those medications that lower your blood sugar by making your kidneys put more sugar in the urine. I don't know if anybody here is on those. They're great medications, though. They have a real good track record for decreasing heart disease and CV risk. So I don't want to talk you out of them, but just have a conversation.
Okay.
Should also mention, sorry, Maya, I was thinking, if you're on immunosuppressant agents, so if you have lupus or you have rheumatoid arthritis, some of those can interfere with healing. So you may talk to your doctor, your rheumatologist, about holding those medications if you have a wound. Same with some of the cancer treatment medications, they can interfere with healing. So again, looking at big picture, you just want to make sure all the providers and nurse practitioners and doctors know your medications and if you can hold them or stop them.
Excellent. What would, if somebody wants to come to the wound care, what's the process? They do require a referral? Is that correct, from a provider?
They do require a referral. It could be from a podiatrist. It could be from your primary care. It could be from a surgeon. And then we can put the number back up. You can call and yourself as well. And sometimes they'll get you scheduled and while they're waiting for that referral to come in. Okay.
Great. And I actually have put the phone number up for anyone who is interested. The phone number is 520-324-4220. So if you are interested in an appointment, please reach out to the TMC Wound Care and they'd be happy to explain whatever the process is if you need, or an appointment for that as well. Natalie, I want to thank you so much. That was all the questions that I had that came in online. This was great. It was a great overview, I think, for people to learn more about what they need to do to take, particularly to take care of their wounds. And I'm going to wrap up with our online audience and I'll turn it over to you for anything in person. Thank you again for being here today.
Thank you. And thank you to our online members and your great questions.
Thank you. Thanks for joining us. We are going to be back tomorrow for another diabetes talk. We're going to actually be talking about blurred vision, navigating macular degeneration, and diabetic eye disease. If you are interested in that class, please give us a call and we'd be happy to get you registered. We do have still some there are still some seating in person along with online. So if you would like to register, the phone number is 324-1960, and that is area code 520. Again, 520-324-1960. We hope to see you again soon. Thanks.